Hello friends, today we will discuss maternal medicine. Firstly, we will discuss physiological changes of pregnancy. Physiologic changes of pregnancy. Then we will discuss some pathology and ultimately we will discuss medical emergency. So firstly, we are going to discuss the physiological changes of pregnancy in different systems. So firstly we will going to discuss bone metabolism. What are the changes occurs in bone metabolism? In bone metabolism there is increased calcium absorption from the intestine due to increased vitamin D. And there is also increased parathyroid hormone. And this parathyroid hormone comes from the placenta and breast. So this vitamin D causes increased calcium reabsorption, and this parathyroid hormone causes bony resorption resulting in hypercalcemia, and ultimately there is a decreased bone mass, skeleton destruction in maternal body. So there is decreased bone mass in maternal skeleton, and there is increased alkaline phosphatase in pregnancy. It can rises up to 4 times. This alkaline phosphatase comes from placenta and this does not indicate obstructive jaundice. So this is all about bony metabolism during pregnancy. So major changes in bone metabolism takes place to meet the demands of the growing fetus. Intestinal calcium reabsorption increases due to increased production of vitamin D. Calcium is also released from the maternal skeleton due to increased bone resorption stimulated by the production of the parathyroid hormone by breast and placenta. This results in loss of bone from the maternal skeleton during pregnancy that continues until lactation ceases, then recovers. Serum concentration of alkaline phosphatase can increase up to 4-fold, and this is from placenta rather than the bone. What are the cardiovascular changes during pregnancy? So heart rate and stroke volume increases during pregnancy, and there is a peripheral vasodilation, reduction of systemic blood pressure causing hyperdynamic circulation, increased cardiac output. There is elevation of diaphragm causing some ECG changes, like patient having mild left axis deviation up to 15 degree. There are some T inversion like in inferior lead like lead 3 and AVF, ST depression, small q, and a sinus tachycardia. Supraventricular and ventricular beats are common. Echocardiography shows a modest increase in the dimension of cardiac chamber. So again we are discussing cardiovascular changes during pregnancy. Cardiovascular changes. So there is increased heart rate and increased stroke volume. So equal to, there is increased cardiac output. There is peripheral vasodilation, so resulting in peripheral resistance, decrease of peripheral resistance, and so there is increased cardiac output and decreased peripheral resistance, resulting in decreased blood pressure. And the circulation is hyperdynamic circulation. And there is sinus tachycardia, and there is elevation of the diaphragm, and there are some ECG changes, like ECG shows left axis deviation up to 15 degree, and there are some ischemic changes in the inferior leads. There is sinus tachycardia, and sometimes supraventricular or ventricular ectopic beat. So this is all about cardiovascular changes during pregnancy. So now I'll discuss endocrine system, the changes of the endocrine system during pregnancy. During early pregnancy, there is secretion of human chorionic gonadotropin by trophoblast, which act on the corpus luteum in the ovary to stimulate estradiol and progesterone production. Level of beta HCG rapidly rises in the early pregnancy to reach a peak about 8 weeks, then fall before stabilizing at lower level before 20 weeks until term. There is progressive rise in estradiol and progesterone level. Initially, these hormones are produced by the corpus luteum, but placental production takes over at about 12 weeks. The high level of gonadotropin suppresses pituitary gonadotropin production, but prolactin rises about tenfold. There is increase in the volume of anterior pituitary. Serum level of T3, free T3 increases during first trimester, but paradoxically thyroid stimulating hormone level fall by 50%. This is because HCG is homologous to TSH, mimic the effect of the TSH on the thyroid gland, stimulating both T3 and T4 production. The raised level of the T3 and T4 feedback to pituitary and reduce TSH secretion. Later in pregnancy, there is increased production of increased degradation of thyroxine by placenta, and the level of the thyroxine binding globulin rises, causing normal range of free T3 and T4 to fall progressively during course of pregnancy. Although TSH levels are difficult to interpret in early pregnancy, they provide best measure of thyroid function at about 16 weeks of gestation. Now again we are discussing what are the endocrine changes during pregnancy. Endocrine changes. So the estrogen and progesterone level goes up throughout pregnancy. Prolactin and this estrogen and progesterone causes suppression of pituitary hormone. All pituitary hormone are suppressed except prolactin. Prolactin goes up about tenfold. Prolactin. There is increase of beta HCG in the early first trimester. It goes around 8 weeks. The beta HCG level is the highest. Then before 20 weeks, it goes to a minimal level. This is beta HCG. And there is another hormone, placental lactogen, which goes up throughout pregnancy. Human placental lactogen. And this causes resistance to tissue for insulin. And ultimately, after 20 weeks of gestation, there is gestational diabetes mellitus. In gestational diabetes mellitus, usually fasting blood glucose level is normal, but postprandial glucose level is high. So that is due to tissue resistance to insulin by human placental lactogen. And another thing is the thyroid hormone. Thyroid hormone, due to having high level of beta hCG in first trimester, the beta hCG mimic thyroid stimulating hormone. Thereby, during first trimester, FT3 and FT4 level is high. But during second, third trimester, when there is no beta hCG, T3 and T4 is broken down by placenta. Thereby, the T3 and T4 level falls during second or third trimester of pregnancy. And there is also thyroid binding globulin, increased production of thyroid binding globulin by liver during thyroid binding globulin. During third, second and third trimester, there is increased thyroid binding globulin, but there is decreased FT3 and FT4, and TSH level becomes normal to high in the second or third trimester, but it is low in the first trimester due to high level of FT3 and FT4 due to beta hCG effect. So this is all about endocrine changes during pregnancy. So there is a picture in the Davidson. We can see during the first trimester, the T3 and T4 level is high, but during the third trimester or second trimester, T3 T4 level is low, thyroid binding globulin level is high, and also we can see the hormonal changes like human placental lactogen increases over days, progesterone increases over days, estrogen increases over days, prolactin increases by the pituitary gland, and there is also reduction of the beta hCG during second or third trimester. So this is all about endocrine changes. Now I will discuss respiratory changes. Respiratory changes, the tidal volume increases, residual volume decreases, vital capacity, residual and the respiratory rate unchanged. So discussing the respiratory changes, there is increased tidal volume, almost 200 ml tidal volume. The residual volume decreases, and ultimately respiratory rate remains unchanged. So patient having some sorts of hyper activity of the respiration resulting in washout of carbon dioxide. So PCO2 will be low in the circulation, and pH remains somehow alkaline, slightly alkaline due to washout of carbon dioxide. Though there is some increased bicarbonate excretion by the kidney, which somehow offset the action of washout of carbon dioxide. So this is all about respiratory changes during pregnancy. There are some hematological changes during pregnancy. So hemoglobin level normally falls about 20% during pregnancy. Plasma volume increases. Thereby there is physiological anemia. There is increased production of coagulation factor. So there is also always a hypercoagulable state that increases the risk of venous and arterial thrombosis during pregnancy. So this is all about different changes of pregnancy, and we will discuss a chart. This is from the Washington Manual of Emergency Medicine, where we can say the physiological changes of pregnancy in a summation. So here you can say blood pressure decreases, heart rate increases by 70%, cardiac output increased by 40%, stroke volume increased by 25%, vascular resistance decreased by 20%, blood volume increased by 40%, coagulation factor increases, red cell mass decreases, WBC count decreases, glomerular filtration rate increases, renal blood flow increases, blood urea creatinine decreases, urinary excretion of protein increases, tidal volume in pulmonary system increases by 40%, respiratory rate little or no change, minute ventilation increases by 40%, vital capacity unchanged, APV1 unchanged, residual volume decreases to 80%, due to elevation of the diaphragm, functional residual capacity decreased by 20%, and inspiratory capacity increased by 5 to 10% due to decreased functional residual capacity. So this is in a nutshell about the physiological changes of pregnancy.